right. Well, good morning, everybody, and welcome to our Friday Power Talk series. I'm very happy to introduce today's speaker. He has well known to us. I've both Dr. Semino and I have worked with him. So Dr. Abel Coe, he's director of the Institute for Public Health and Medicine for the Center of Health Information Partnerships, also the director of the Institute for Artificial Intelligence in Medicine and professor of medicine at the Northwestern University Feinberg School of Medicine. He completed his MD from Medical College of Wisconsin, residency and chief residency, also at University of Wisconsin Internal Medicine, and NIH fellowship at the Regan Street Institute. He is very well known in the field, very prominent. He's been PI of many large regional collaborative projects that have been funded by the ONC, and his research focuses on developing ways to bring together EHR data, data sharing platforms, and high throughput phenotyping, many different other projects. So I'm happy to introduce him right now, and then just Dr. Coe.
Great, thanks, Amy and Jim. Thank you for both. Hopefully, can you hear me? Okay, does everything sound okay? Okay, all right. So this is going to be kind of loose and maybe more of like a personal journey. So it's going to be sort of like a storyboard from when I moved back to Chicago after Regan Street to where we are today. But I'll throw in some informatics stuff, the latest stuff we're doing right now. And you can always, put things in the chat and stop me because, like I said, this is kind of like just I combined. Amy suggested that you could be like kind of, story and or informatics, and I kind of did both. So, okay, I have one disclosure to make, and there it is. And actually, that's part of the story a little bit. All right, so as Amy mentioned, I was at Regan Street. I'd gotten involved in some of the HIE work. I moved back to Chicago because, that's my family's from, and I was born here. So, we had this idea that we could build on some of the principles of health information exchanges and try to create sort of a more complete story for individuals. At the time, it was one of my first projects I got involved in was the eMERGE network, which was a predecessor to the All of Us research program. So it's about electronic medical records and genomics. And the idea there was to try to use electronic health record data and link it to genomic data and see if you could basically replicate more traditional prospective studies. And that seemed to work pretty well. So applied the same principles and thought, well, could we sort of identify sort of patients and their conditions across the city of Chicago? And as we sort of started thinking about it, what came up as a community need was the story of populations and the health of the city. And that became one of our early projects, and a project that was initially called the Chicago Health Atlas. That was one of my first grants. It was funded by a local foundation. And the idea was that if we could bring together data from across the city, we could create these sort of heat maps that would tell us sort of where there was disparities and issues with the health of the population. So, building again on some of the work that we've done in Indianapolis, I first started out by looking at sort of what's the distribution or catchments of populations across the city of Chicago. And anyone who's been in Chicago knows there's like a ton of competing institutions. So if you bring them all together, like these are different catchments of 500 hospitals that were initially in our health atlas, you get something that's a pretty good saturation point. So you get to a place where if you bring enough health systems together, you can get to some reasonable percent of coverage of the population. And that's kind of what we did. But what we also recognized was that while we compete as hospitals, we're also a city, you could flip it the other way around, is that there's a lot of choices for patients. Patients could go to a lot of different places for care, and they do. And we really didn't even know to what degree that happened. I mean, I had a sense because in the HIE work in Indiana, I knew that for certain types of conditions, like infections, for example, people moved all over the place. And so based on that, we set out to try to figure out if there was a way to link records like you would in an HIE with a master patient index across the city of Chicago. But the problem is we had no functioning health information exchange. We still don't. It's a very competitive environment. And there just wasn't a value proposition. And as we watched HIEs develop, we sort of realized that, you had to have some sort of value prop built into it. Well, the value prop in our instance was that we got a bunch of researchers together, and we propositioned them in essence and said, hey, look, we're all informatics people. We get along really well. We trust each other. Let's build a central repository of all of our data. And this was for 7 institutions. Let's take a one-time cut of your data, and then we'll come up with a way to link that data together and then create essentially those maps. And then everybody benefits. Everyone who puts data in can get data back out through this governance model. And that's kind of what we did. We created this HealthLink model that was sort of extant from 2008 to 2015. And it was about something in the order of about 3 million records that we got sent as a one-time cut. And then what we did is, we pragmatically were trying to solve problems. So with linkage, we didn't have an MPI. We wouldn't get an MPI. And then working with a couple students and a few other folks, we came up with this sort of idea. And there had been some prior work done in this space. We said, oh, actually, we could create a cryptographic hash, which in the regulations and the HIPAA regs, there was an allowance for that, an allowance that a cryptographic hash of patient features of PHI isn't considered PHI and could be shared. And so with that was sort of little, idea in mind, we were able to build out sort of a system initially with students, and then later on we sort of, hardened it so that you could go ahead and get data from across all these different systems and create not just one identifier, because people have misspellings and all that kind of stuff. But after some extensive pre-processing, we would create 20 different versions of a person, knowing full well the hash of those features would be unique. It would be really unique. In other words, if it was a match, we had a pretty high confidence it would be a match for that person. And so that's what we did. We sort of thanks, Amy. I'm going to try to track that chat as I go. And so we did that. We wrote a paper about that with a whole bunch of people. This was like a team of many people, many of which we still keep in good contact with, and who became the basis for our community sort of network. So one key early lesson was that, a lot of these problems, you certainly don't want to start out with the solution. You want to figure out what the real problem is, and then you work towards that solution. And along the way, if you can build the network, you can overcome some of the socio-technical, or rather the social and political problems that really are the issue that kills these things. The other thing was trying to find that shared value. And so as long as you have a win-win situation, you'll be fine. But there always has to be symmetry. People have to get something out or they won't put in. And so I think this was probably one of the bigger lessons that we learned from this whole process. One thing that we did start looking, though, is that when you start weaving all these records together, in addition to the duplicates that we saw across the sites, which were significant, 24%, upwards, is that we started to notice that if we got enough saturation over the whole Chicagoland region, you started creating what looked like a representative sampling, not perfect, of the city of Chicago. And this was sort of a comparison we wrote in our paper that looked at how well do these cut points, these 5-year bins, look compared to census for the rough same time frame. And what you see is that, it's pretty close for a lot of the buckets, which is good. So a reasonable sampling across age groups, except for young people who don't come in for routine care all that often, as they should not. And so for that, we underrepresent. And since this work, there's been a lot of parallel work that's happened in the world of how do you measure population health using EHRs. Actually, it's not a solved problem, but groups like the group in New York City, we went out to visit them. They had done some work, and they continue to do work, and CDC does work still on how do you take this data and appropriately weight the data so that it then does become a representative sample. If you think about how we currently do population health, we actually do by survey. Polls are the same, actually. And so you go ahead and survey a population and you figure out how representative it is of the catchment, and then you adjust accordingly. And that's how we get a lot of our estimates for disease in this country today. But we were hopeful that we could get to far more like broad set of conditions by using EHR data and still get an accurate representation of the population health disease burden, which I think a lot of the studies, not necessarily from us, but from other groups, have shown that it is possible, certainly for chronic diseases or diseases that are typically measured from within health systems or require some sort of like health system contact. Along the way, though, like, we started out with, a bunch of us in a room, we're like all informatics people. We thought, we can pull this off. But then we started recognizing that, other people got involved. They got less and less comfortable with the idea of one institution getting this one-time cut of data. So again, in response to some of those needs, in 2011, myself and two other people, Bill Trick and Balahota, one was at Rush, one was at County, and I was at Northwestern. We sat down for an Italian dinner on Taylor Street, and we said, we probably should set up something that can, because it's like today, like if you think about your work today, like every academic medical center has a few informatics folks, but there's not enough of us. The same is true in a large city like Chicago. And we said, what we need is we need an entity that's going to be a neutral, that people can trust, that is not beholden to one institution. It needs to be able to house expertise and spin that up really quickly. Has to have like certain types of technical capacity. And so that's what we did. So we stood up. It was like one of these discussions where we're like, well, what do we call it? And so we scribbled down, we said, well, we'll call it, we just listed what it would be, like Medical Research Analytics and Informatics Alliance. That sort of captured sort of what it was. And we said, that's a super long, we'll change it later. And of course we never did. So now we stuck with it. And since 2011, it's been called Mariah, and it acts as an honest broker. It's done a lot of work also for state of Illinois. So during COVID, we did some work. Record linkage, we've actually released open source record linkage. So if you go through Mariah, there's actually open source software called Linkja that anyone can use. And so we've continued to act on this initial core mission. All of us are volunteers, all the board members and the founders. We volunteer our time. We meet, whenever we need to. And we try to sustain the organization, but because it serves such an important benefit. We've expanded the board, so the board now includes people from the University of Chicago, some people from outside Chicago. But this has been a really nice model. Like anything, it's an organization. 501c3s still need to be sustainable. And so we do spend a lot of our board meetings thinking about how do we make sure that there's the right leadership in place and that there's a path to sustainability. And what you will see is that these are all synergistic now. So Mariah receives some of its funding from our other work and enables some of this other work because there's no one institution that can step in the gap quick enough with low overhead to be able to deliver the service. So that we think of this as like an informatics shop, like a nonprofit informatics shop for our region. So that's been really a fun thing. So with Mariah in place as the honest broker, with this, we've created now like a shared governance model. Now we had existed in 2008 to like 2011 on our own, 5, 6, 7 years. Along came funding in the form of PCORI funding. And so we sort of built out a little bit of additional infrastructure. And so now what we did is instead of using a homegrown common data model, we mapped our data to the PCORNet common data model. And then, and we've been using that since. We do have some instances of OMOP for those who are familiar with common data models, hidden underneath the hood in a lot of our places. But for the most part, our queries, initially they were Capricorn common data models. Now they became PCORNet common data models. And now we're experimenting with sort of, I would say, more pragmatic or machine learning driven data models is our current line of research that I won't talk about in this talk, but there's a fair amount of our AI work is going that way. But the way this works is, any site can go ahead and ask a question, gets approved by a steering committee. We have a central IRB. Mariah, the honest broker, distributes the queries to all the different sites that hits against their common data model, returns back results. Mariah compiles them all, sends them back to the client. And so that's the current structure that we have in place. then resulted that David Meltzer came up with a great name, and so we shifted over from the Health Data Repository to the Capricorn name brand once we became initially a member of PCORNet, and it stands for this acronym. And the origin story there is that apparently David, in one of our first meetings, was thinking about this in the shower. I don't know what to make of that, but it's stuck. So now we have Capricorn as our name, much like Mariah. We just have these names stuck now. So at the time, this was the sort of the network. This was like the network of sites. Some of the names have changed. Some of the ownership has changed since, but this was sort of what had come about. Early on, we started getting approached because we had this population level, conglomeration of data by a number of different groups. And one was like the VA, for example. The VA approached us about figuring out whether or not veterans seek care outside the VA. And we gave us some money. We're like, oh, okay, people will pay us for these queries. And so we answered the question for that set of VA hospitals in Chicago, published a paper about that. The next thing that happened was a number of, we would have these health system leaders meetings. And at one of the health system leaders meetings, all of them said, what's a big problem for us? And again, this is the shared value thing. They said, we all have homeless patients in Chicago, and they're some of the highest utilizers of care. We also know that there's efforts in the works to try to provide free housing and wraparound services. But what's not clear to us is that going to really make a difference? Is that going to make a difference in terms of bottom line? And so, we were sort of tasked with this from our health systems, and we said, okay, let's find out. So Bill Trick, again, one of our Mariah board members, and Fred Rockman, who runs Alliance Chicago, they sort of spearheaded this. And that's, again, shared value means also in the academic space, you need to have people get credit and take turns being leaders. And so that's an important part of our model. They took on this task. They met with the All Chicago group, which manages the Health Homeless Management Information System, which is the case for a lot of different cities or states. There's probably one in Alabama as well. And what those groups do, these community-based organizations, they track homeless patients, they also are people, and they also try to identify whether or not they were given housing or not housing. Using some of the record linkage tools we had built, we were able to link those homeless records, individuals, with our health records for across the whole network, and then look at care utilization. And then again, not surprising to anybody who's been in the space, is that if you give homeless patients homes, that they will make better use of the healthcare system. They will use emergency departments less, get admitted less, actually show up in primary care more. And so the net result was likely a pretty significant cost savings. So we published that. This work has continued unabated. And so since that initial set of papers, there's actually, I didn't put this in here, there's another JAMA paper that just came out from Matt O'Brien that builds on this. And we have ongoing funding now from the Pritzker Foundation. So the governor's nonprofit foundation funds a lot of this work. And so this work has continued unabated. At the individual level, you look at individuals with homelessness. What's interesting, and Bill Trick did this analysis, is that, if you look at the diagnoses, go beyond just care utilization, you see that, a typical homeless person out in exposed is going to have a lot of health issues like exposure to the feet, for example. Footwear is actually remarkably a problem, like a huge problem. But then when you give people homes or stable housing, that drops off the list. It drops really far down the list. Other ones still persist, but and this can give us a little bit of clue about sort of how and what types of interventions would be needed for homeless populations. And so this has been not just a population level, but an individual level sort of intervention study that we've been engaged in now for a while. But here's the, we oftentimes tell you about things that went well. I'll tell you what didn't go so well. So, we were in 2 rounds of PCORNet. And then in 2000, I think it was 2001 or end of 2001, we were basically told we're out. Like we were unceremoniously booted as the, I don't feel so bad because the people that got booted before us were like informatics luminaries like Sean Murphy and Wasila Ono Machado. And so I was like, well, not a bad group to join, but there was unclear all the reasons why, but I do know that we had scored really well in our grant review, but for various reasons, I think maybe we had some differences in mission. We were let go unceremoniously. That was pretty hard because while we existed before BCORnet, over those 8 years we had sort of, well, the money's helpful. It helps you build stuff, and it gives you a little bit of sense of like a community, and you're feeling pretty good about things, and so that was pretty hard. Um, and I remember because it was like depth of winter in October, and a lot of things happened. My dad died shortly thereafter. There's like a lot of weirdness going on at the time in my life. But it was really gratifying because, we as a community, Chicago, like it was funny when we had our post-mortem, I fully expected the network was going to just stop. It was going to fold up. But there was like a really, I can't tell you how much it meant. We had again, sort of dead of winter meeting. And it was, every single person around the table was like, with sometimes colorful language, was like, nah, no, just simply no. Like we know what we can do. We know what our score was. We know what the metrics look like. We had every right to be there, and but we don't care. We're going to do it. We're going to keep going. And so what we did is we actually had a small retreat afterwards, and we, as a group, tried to get back to our like roots. Like, what is it that we really value? What's the value for Chicago? What's the value for our health systems? What we came up with was three things that are core to our identity as a group working together. What those are is that we really believe in the health of the population of Chicago. So that's like a core pillar. We believe in health equity. Like everybody should have a chance. Everybody should have an equal share. And so health equity. And then the last thing is like what we're good at, we think we can do technical innovation. I think we can because we have this petri dish of people working together. We have an environment in which we can test new technologies faster and better than other places can because we have in some sense solved the socio-political issues that really kill a lot of technical or even informatics projects. Because if you don't have empathy or sympathy or honesty about the problem and how it affects people, then you're just not going to succeed in building on informatics tools. And so this was really, a really gratifying moment. But we knew it was going to be a tough slog. And so I think myself and our team, because the Capricorn Network is administratively led out of Northwestern, I felt I'd let everyone down. Like, we have this funding and we lost it. And it's like, it's on me, But when everyone sort of galvanized together, I was like, nah, we're gonna carve our own path. So now, a couple of years, 3 years later, we've I would say made the turn, which has been really gratifying. We've continued to grow. Some of the names of these things have changed, but everyone is stuck together in keeping the network alive and well. We have been forced early days to become sustainable on our own. Now, we had some leftover funds that sort of trickled down in 2022. 2023 was sort of like the low point. And these are investigator-initiated queries from the network. Now, it's not huge, but what this does is this allows us to maintain our infrastructure. And so we pop back, and so you can see it sort of popping back up in a growth curve that you'd like to see for any sort of startup or company. But what's even more encouraging is if you look at the total numbers of funding, we really popped. And so as of this past year, we're over like close to about 1.5 million in funding now. And that's through a combination of investigator-initiated research projects. And I would say that there's a number of faculty now that rely upon Capricorn for their R01s or their funding. And we're very lucky because we have so many AMCs and great faculty that can do this type of stuff. And so this has been great. I mean, to us, it's kind of like, the best revenge is living well. And we're like, all right, sure, we got knocked down, but guess who stood back up? And so we're back up on our feet again. And that has been really exciting. What's even more exciting is that folks who really know about population health, like Sinai Urban Health Institute, who have been one of the early pioneers in measuring the health of populations, they're like, we'd like to join. We'd like to become part of the network. Access Community Health Network, the largest network of FQHCs. They're like, we want to join. And that's important because, you know, as I mentioned, these EHR data, you want to weave them all together. The more you have, especially from certain populations, you're going to have better representation, better. And again, everything goes back. We have three pillars: population health, health equity, technical innovation. And so these networks align with our pillars, our priorities. And so now when we make decisions, we have a set of principles by which we operate. So what that's nice about that is it means the organization has an identity, and, you know, whether or not whoever's in charge or whatever, it's going to keep on going. So that's been really gratifying to see. Over there in the left corner, it's also gratifying to see who's come in. So that's our new commissioner of public health for City of Chicago. We worked long and hard with them. They believed in us. And now we're helping to pilot how do you measure population health across City of Chicago using our network. So that's been great. And they provide a significant amount of funding for that. People are interested in climate change have come to us. So Professor Dan Horton at Northwestern, and I'll show you some of those slides later, has been working with us to try to link, you know, weather data, extreme weather event data, with our health data to understand the impact on health. We've been looking at a partnership, and we have now agreement and a small grant with our school system, the largest school system, our Chicago public school system, through Terry Sabel, one of the researchers up on the North Campus. And we're looking at linking school data with health data to try to understand things like policy, like how does school lunch systems or school lunch programs affect obesity rates, for example. And then on the technical innovation side, we're very excited because I'll explain to you some of the other work we're doing now with Dr. Jenny Rogers and Xiao Wang, who are experts respectively in privacy enhancing technology and cryptographic methods. So again, this has been sort of a fun sort of technical innovation side of the work we've been doing in Chicago. All right, so I'm going to jump in because informatics, I'm going to talk a little bit about this because it's exciting work. And so as I mentioned to you, we had done a lot of work in privacy preserving record linkage. But way back in 2015, when we were like in the process of spinning out a company and then building that out, we recognized early on that there's some limitations. You know, PPRL, you need an honest broker like Mariah, but not everyone can just create an honest broker out of thin air. And then the most important thing in here is that what we realize, even in Capricorn, that there are certain queries that institutions won't participate in because you're part of like I say, quality improvement study, or you might reveal something about your institution that you just don't want anybody to know. You know, maybe it's something, could be something as simple as the number of patients who have Medicaid or you know, have some, you know, quality measure that they're doing well on or not doing well on. Now, today, the current state is that people give those data to some sort of honest broker. But I think the future is not going to be that. I don't think we're going to, I think that's a solvable problem, and people don't want their data floating around everywhere, copies of their data sitting in place after place after place. That's not a real great from a security and privacy standpoint. And as we see from the number of breaches every year, it's a big risk. So the other thing is, because you need an honest broker, that means you also need to have a ton of legal agreements. And under the hood at Capricorn, we have put in place legal protections across all our institutions. And that is a long time. I think in some instances, about a 2-year cycle to get these things inked. So that's a huge problem. And that's, again, why we said, well, let's think of, is there a way around this? Enter in Dr. Rogers and Wang from computer science. And so we've been working now together for since 2016, so already 8 years. Xiao was recruited. That's his recruitment photo, I think, because he looks really young. We've all aged, I would say, gracefully, but Xiao is now like all of us, older. But what we in talking to them, we sort of talked about a couple different possibilities. There was like differential privacy is one method, but there's issues with that and how understandable that is to clinicians. There was fully homomorphic encryption, which is great, but at the time, and still I would argue, pretty tough to implement in real world settings. And then we came upon this thing of secure multi-party computation. And this, I remember being in a conference, a privacy conference, and hearing about it. And one of the companies was explaining their use case. I think it was, I forget which, I don't want to get it wrong, but like, was this, it was like, hey, sometimes there's in situations where nobody trusts anybody else, like in the, like warring countries might all have satellites. Those satellites are up in the air. They're really expensive to get up there. If they crash or collide together, you lose a lot of money. Everyone loses money. So there's a shared interest in not crashing. But you also can't reveal where your satellite, whose satellite is hovering over whose country, because that, people don't want to be like, it's a little awkward to say that you're spying on somebody. So they came up with this secure multi-party computation sort of algorithm in this paper that said, hey, we could come up with a way that through encryption, we could obscure the identity of the data, but more importantly, the identity of the contributors to the data. So could you contribute data in an anonymous fashion to a shared computation? And in this method, with this MPC, you could. So we set out working on building this. And so since 2016, spearheaded by Dr. Rogers, she and her students built out this platform, this thing we call Vault DB. And it allows us to basically implement multi-party computing through a Dockerized piece of software. And the idea was that for 2 or more data partners, they could contribute data to a shared computation anonymously. The other thing it does is, even though we took a lot of time to build an honest broker, it could, in theory, replicate the function of an honest broker through this through a encrypted compute partner without the need for the compute partner to ever see inside the box. So it basically creates an angelic honest broker who cannot see inside the box. That means you don't have to trust the person. You don't have the man in the middle type attacks that go away. And so that's what we did. We built this out and figured a way to basically take out an honest broker. Although we still use it for purpose of validating that the results are the same as if you did it with sort of a traditional method. This is the early pre-pub version. We're working on the next one. And so we got this up and running over 3 systems, 13 million records, and we're able to generate sort of an output table that looked at the distribution of hypertension control across the city of Chicago for a large number of patients. And so this was sort of proof of concept that MPC can be implemented in a real world setting. This is a very similar way that which we implemented PPRL. We started out with a handful of people that were interested in trying out new things, and then we sort of grew from there. And so we then were approached, maybe a year and a half ago by DARPA. So they're the Defense Advanced Research Project Agency, and we got on a phone call with them, and they said, "Hey, we heard about this work you're doing with MPC. We'd like to work with you." And we're like, "Okay, great." And then we got a call back, like I don't know, a day later. They're like, "Hey, we said we didn't care about health that much, but we are a defense agency, so can you involve the VA?" And so we said, "Okay, sure." So then we reached out to our colleagues at the VA, and they said, "Okay, here's some funds. Go ahead and build this out." And so this Catalyst project, we've been working on it. We just actually had our closeout call yesterday for the first stage. And so what we've done is we basically tried to take an existing query that we already know worked, this FAME query, and then replicate it within a multi-party computing framework. And that's what we've done. This is the team. It's been a lot of fun working with a company, which is Stealth Software Technologies, with some rather famed computer scientists in the mix. There's ourselves and our less esteemed group, and then folks at the VA, and then and University of Utah, who was our conduit to the VA. So this team's been working now for about a year within Capricorn. These are the Capricorn sites that were involved and the number of people, the people that were in the mix. And then here are the study roles. The way the MPC protocol works is we had some parties that contributed both data and could perform the encrypted compute. We had some that just did the encrypted compute, and then some that just did data contribution of some sort. And the interesting part about these models is that nobody at any point in time sees the input, what's inside the black box, until it comes out the other end as an answer. And so the thing what we realized working with MPC is that you have to think about queries in a different way. You sometimes have to think of your answer, like what the form of your answer looks like, and work backwards to the query. And I can go in more detail about that, but it's a little bit different way of thinking about distributed queries. So this project, oh yeah, I should have mentioned. So this project now we just finished. We got 6 sites to install and run the software, these 6 sites. And as far as we know, and as far as DARPA knows, this is the largest real world implementation of MPC, certainly in health. And so we're pretty excited about that. I think it's over 10 million records. And so we were able to show that also computationally scales. And so we think that this is now in a much better place for routine use. So I think we're in a place now where we're thinking of how do we make this a tool available to people who want to get insights from data without sharing their data with an honest broker. So this is a new technology, again, technical innovation within Capricorn. Now, the other things that we've been doing is still working on a lot of other types of projects to link data. I'm a big data linkage fan. So we've been working with the Buffett Institute and Dr. Dan Horton. And in this instance, they, weather is geographic. It's time and it's space. And so we've been working with Cole Brokamp and his team over at Cincinnati Children's to get this great tool called DeGauss, which is basically a distributed geospatial mapping software tool. It's kind of like a Dockerized version of geospatial mapping. Love it. We've been able to add things to it and add different components to it. Our health system now uses it to geospatially code all of our patients, our data warehouse, and make that available back to people. You can link that to census records and American Community Survey data. So it's been really fun to do this. And so we have a project now where we're working with many stakeholders around Chicago, and we're able to take all these different data, link it together at a very fine level of geography. So now we can link individual level data at 1 kilometer squares, and then pull in environmental data and other data like death data. And so this has been a very fun collaboration working with across all our partners, other schools, public health, people who develop technologies like the folks in Cincinnati Children's. So this has been a ton of fun. And it's actually been so much fun. I have 2 PhD students working on it. They actually now have a lab, even though they're PhD students, they have a lab in a lab. So now I just send people to them and they take students of their own on, which is kind of crazy, but there's students now running their own student team. So Peter Graffy, Ben Barrett doing amazing work, building this whole functionality out. And here's just some requisite maps that show our ability to see sort of like the distribution of extreme heat events in the city of Chicago, which is not surprisingly geographic and driven a lot by lake effects, actually. And mostly coincides with areas where there's poor health outcomes, but not always. I'm probably close to time. So this is the last slide, I think. So the other thing that we've been doing is we continue to build out on our data linkage work. This is more of a plug. A couple of years ago, I attended an international conference, the International Population Data Linkage Network Conference. There's actually a really super weird story about this one too. So back in college, I actually studied abroad at a university in Wales, University College of Wales, Swansea. And I, did my pre-med requirements there because I was an engineer in Champaign-Urbana and I couldn't, take my coursework there. And fast forward, sort of Swansea University became sort of like the world leader in population data linkage, weirdly enough. And so, I had a chance at this conference to go meet with them and then meet with some of the folks in Swansea and meet some friends I hadn't seen since when I studied abroad. And then we ended up then hosting the conference. And so this past year, we hosted the IPDLN conference in Chicago, had about 600 people attend, including about 50-something people from Swansea. So it was really kind of a fun, weird coincidence. And the next one is going to be in Rotterdam in 2026. So if people are interested in record linkage, this is a fun conference to attend. Very international, very sort of a inclusive group of people. But yeah, so that's my story. Somewhere in there is informatics, and I'll keep the screen. Actually, let me stop sharing because so I can see people's faces, and then I think that was the request to do that in 15 minutes question. So I can. Oh, I see some questions, so I can either do those directly or however you want to do it. So I'll turn it back to you, Amy, and yeah, thank you.
Yeah, thanks for the great presentation. It was kind of a treat to have it be as a story and showing your journey personally and your projects. I would, we normally think, oh, public health, that's CDC or local board of health or something, but I think it's interesting you've shown that this can be done through HIE and data sharing. There is a question from Hasib Musawir, if I'm not pronouncing that too badly.
Yeah.
I don't know if you want to address that.
Yeah. Thank you, Hasib. So, we have been huge fans of data standards and terminologies for many years. One of my first projects was at Reagan Street was doing a mapping project with Clem, and but the FHIR standard is like any implementation standard, like HL7 standards. Real world implementations are always, I would say, not as good as the specs require, because you have people involved oftentimes in making decisions about how you map certain content into different components within a FHIR sort of compliant message, for example. And so we actually have done some work on taking a FHIR first approach of taking data from electronic health records, converting it into FHIR format, in mostly either transactional or batch, loading into now what we call our lake house. I think it's called a lake house now, not just a data lake, and then converting that over then to an OMOP. Our observations to date has been that has been an imperfect process. There's probably lots of reasons for that along the way, but what and maybe this gets at your second question about APIs. I do think so. Like, an API is just an automated means of connecting to an endpoint, and I think the elephant in the room is that so long as people are involved in a dependency for doing data translations and integration, you're always going to have errors. You're going to have big problems. It also won't scale super well. So I like the idea of APIs. I think we have to use APIs, though, as just one component of a process that removes as much human intervention as possible. So the work I wasn't going to mention, but I will mention now, is that some folks in our group, like Teresa Wallace and others in our group, we've been trying to build automated mapping tools using multi-dimensional embedding, so data-driven approaches to creating common data models. And we think that'll work well, even though there is uncertainty, like LLMs, like you might ask an LLM, and it'll like come back with 10 times you ask it, and it'll come back with something different each time. That's fine. What we've come to realize is that medicine is far more about uncertainty and probability than it is about certainty. And we've probably taken a funny tack over the past years where we basically convert what is uncertain things into certain mappings, and that has not worked out super well. So we are going to continue to explore whether or not we do data-driven data transformations and data modeling. If those work, we would of course tie those in through APIs, but the underpinning, like what do you feed into the API, that's the part we're really focused on right now. Because for all the work I talk about linkages is one part of data integration. There's data linkage, identity, that kind of stuff. But under the hood, then you need to have verification that the data has a certain format and is conceptually correct. There's also a space in there for other types of technical innovations, like zero knowledge proofs. So let's say you've record linkage, you want to link on things that already standardized to a common data model. Great. Well, how do you verify? You do quality checks on the data. How do you verify that the compute over that data is also mathematically valid or unchanged or similar enough? So there's a whole body of work I think that needs to be done to also dive into the under the hood and look at like, you know, yeah, how do we automate and standardize enough the processes and data that you're computing over? And I think there's a huge opportunity there, you know, from a AI machine learning standpoint today. Oh yeah, so data coming from big EHRs already taken care of? No, no, absolutely not. Like data coming from big EHRs is messy as all get out. Anyone who's ever worked with EHR data, it's a disaster. And but what we do is we sometimes make the problem worse by taking those data and then saying, we are going to assign this concept to this terminology code, even though we may know that's wrong, you know, like that's not true. The most egregious example that I would say is probably the way we assign diagnoses for death records. So if you look at, you know, death records, it's sure it's like a diagnosis code at the end of the day that you get from CDCs and CHS, but how did it get there? Well, it got there because somebody who may or may not have known the patient says, I think the reason this person died was this, 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 and this. And they have to use these arcane rules for what you can pick. And the end result is it's a mess. And so, you know, EHR data is not as bad as that, but we do also allow clinicians to basically assign diagnoses to certain things. And they might assign those diagnoses for reasons that are not as valid. They might be for billing purposes or for something else. So I would say that, again, and this is like maybe heresy coming in and talking to people who know informatics about like, oh, data standards, not great. Like, it's not that they're not good. It's just that they're, I would say, we're too certain of ourselves when we assign those, and we're also too inconsistent, and we also don't have the workforce for it. So I think there needs to be some sort of, you know, a lot of work done in this space.
Yeah, anybody have any questions or comments? Feel free to unmute yourself, or you can put it in the chat. And you're right, talking about standards being not so great, and EHR data not being so great, talking to a room full of clinical informatics and ontology people. So yes, I agree with you that oftentimes mapping and kind of overlaps with coding has to be pragmatic and sometimes more an art than science. We would like to think everything's black and white and can be perfectly classified, but we know that's not the case. And you said that EHR data is such a mess, but that is the main bulk of what we have. And
Right.
and you're taking an abstraction because you're only taking certain things. I have a
Right.
question about more like administrative. You mentioned that funding had been an issue, and but you're able to get some funding. And I'm wondering how that's not, you're running the program, but what about at the other institutions? They have to have their own support and their own technical people to run things on
Yeah.
the
Yeah.
data. So how's that going in terms of getting support?
Yeah, that funding number I showed you is actually a shared pool. So actually what we set up is, getting with shared governance, we also have a shared recharge model. So we've been when you're poor, you have to optimize everything, and so you're forced to be like very creative in keeping your costs down. So fortunately, like a couple of years back, we're like, this contracting back and forth is just not great. So we set up a recharge model where every institution, and we reassess it every periodically. We all agree upon a price rate. So we all know the hourly rate for informatics people's time, project management time, for different functions, query development, deduplication. So we have like a price list. And from that price list, we can convert that to hourly rates. And so anytime we get a query in, we can essentially multiply the number of sites that participate by some price rate. And then we can give that to a customer and say, this is what's going to cost you to do this type of query for this type of thing. So we have estimates now over many years of complexity of queries, how much it's going to take. We can still do better. I mean, we not surprising with messy data. You get the data and you're like, oh yeah. And then the guy's like, nah, something's wrong. And you have to go back and do it again. So we built and are trying to bake in more like like checks and also more like redos. Like you get like a mulligan, like type stuff. So I think but these administrative things are so crucial, like a central IRB, shared recharge, legal agreements. We spend a ton of years putting these in place. And now like the benefit is even if you don't need an honest broker, even if you don't need legal agreements, it's still nice to have those. It just accelerates the adoption of new technologies and it creates a really nice test bed, which is why I think we get people coming into us and saying, hey, we'd like to run this experiment. Can you guys do it? We're like, yeah, there's a probably good chance we can run it. And so we created a model that's flexible and honors the efforts of local sites. So everybody gets paid. So if we get a big grant, everyone wins. That's how it goes.
Well, that's good that you've did that upfront investment to try to get all those agreements and all that administrative stuff and legal stuff set, so that'd be easy. Because just having all those, even if everybody's got the great science and technology, just having all those agreements not work out, that could make the whole thing fall apart.
Oh
And
my God.
and also
Yeah.
kind of segueing into Jim's question, that you're actually calculating the cost the cost of that query, that how much your resources you're actually using, and that's analogous to if you do some kind of AI or even using large language models, that you have a cost for that as well. But so Jim's question, what's the role in all this for generative AI LLMs? That's what everybody's talking about nowadays.
Yeah. So okay, Jim, my dream, and I think actually I think it's actually really doable, is that a clinician should not have to speak informatics talk. Like a clinician should be able to walk up to us and say, I want to know across your network what is like the prevalence of diabetes. And we should be able to give them an answer. And I think that is absolutely doable because what we're putting in place right now, as I should have mentioned this too, is we are putting in Leaf as a sort of self, use tool. But we've also been working on automated means to extract using LLMs, basically multidimensional embeddings of our data to create clusters within our network. And then so it's basically a matter now of stringing together multiple tools. So under the hood, a common data model where you need it, a vector store where you need it, a security tool on top of a privacy tool, an identity tool on top of that. We think we can create like a whole set of like tools within each site that would allow us to have somebody in the middle of nowhere say, give me the number of patients, and we can get them back an accurate number or accurate enough number for a clinician. So I think this is a very, very doable thing in the very near future.
So you would have to have some kind of prompt engineering, I would think, where you would turn the question into a database question and then turn that into a query. So for instance, the person asks a question, you've got to say, ask the LLM or the generative AI, what is an equivalent question that I would ask a database that this doctor just asked? And so then it would say, well, you have to know the number of rows in this table that have this value and such and such value and such field.
Yeah.
And then you'd have to take that and say, now turn that into a SQL query or whatever. And it could do that.
Actually,
the question is whether it would have enough information to do that middle thing.
It turns out we don't even need to do the conversion to SQL. So we ran a couple experiments recently. I should have put these in here. So one of our students actually used GPT-4o, the latest one, and asked the question using just general knowledge from GPT-4o if it can identify like common immunologic diseases. And we compare that against like rules-based approaches, and it just crushed it, absolutely crushed it. And so you can literally just ask that question now, and it takes the totality of the data that has been vectorized. So we basically have developed it's actually some papers like feed2vec papers and word2vec. You can take and forget all the work we've always traditionally done. I think we have to break that mold. Instead, dump it not into like structured data sets that we do traditional SQL against, but dump the totality of the data into multi-dimensional representations. And then the tricky part now is actually pulling it up into clusters that are sensible. But it turns out the LLMs already have that feature. So you can take an LLM and ask a question of a vector store. It will pull back consistent representations of clinical concepts that we already know. It works amazingly well. And so now it's computationally expensive because we looking at the cost. So I think the cost is for every note we process, it's like 5 cents a note, which doesn't sound like a lot, but it is. Okay, so it ends up running up a bill. So is it the best use? Probably not. So that means we have to then figure out like what are the cost-effective, like nuanced things. So we're trying to now figure out, can we pre-compute embeddings or create groupings so that we have like, so we can basically offset the compute cost, and then maybe then we do use SQL against that. You know, like these clusters, these pre-built clusters, and we work off that. I think this is the way to go. I mean, I think compute costs will come down. This is going to happen. I think there's no doubt in my mind this is going to happen. In fact, I would argue that most of the work we've done in informatics for many years, it's at risk of being completely blown up. Now that sounds crazy. It's a terrible thing to say, but I do think that it's heading that way.
No, I agree with you.
Yeah,
Quick check
Matt,
on time. We're at time, so I don't know if if you're able to stay for a
I can
few.
see for a couple of minutes. Yeah, sure. But Matt,
Yeah, Matt.
thanks, Jim. I appreciate it.
Interpreting that effectively you just use the narrative text notes as the sole source for those sort of things, or is there a process for getting the large scale billions of structured pieces of
both.
data into
Yeah.
that as well?
We've done both, actually. And so it turns out the notes actually seem to have a lot more value, especially for weird conditions like the immunologic diseases. And so it's funny, I talked to somebody and I was like, I was gonna get this 2x2 tables. And I said ran out of time. But if folks are interested in this, it's again, it doesn't work as well if you're using GPT whatever 3.5 or whatever, but the 4.0 version, the one that they charge you for, like does remarkably well in identifying these conditions from like our notes, like plain old medical notes. You process them, but again, the cost will catch you right now. The cost will catch you, and so if you're going to do it, run them as small experiments. I would recommend small experiments. Don't incur the wrath of your CIO. But again, the future. This is the future. I think there's no doubt in my mind this is going to happen. And also as a clinician, this always bothered me as a terminology guy myself. Like we always said, oh, I did the mapping, I did this also. And it was always wrong. There was always like, even if it was really like terminology master, you were basically asserting something that was not true. You were taking an analog event and saying, digitally, this is 1-0. That's not the case. The world is not the case. Most of us are in some variation of less than 1, you know, like it doesn't make any sense. So I think this actually is much more human or analog or loose or uncertain, much like the life we live. Like nobody lives in 1s and 0s.
All right. Well, thanks
Thank you.
everybody. We're at time or past time. Thank you everybody for attending. Thank you, Dr. Coe, for the great presentation. And just a reminder, we don't have a seminar next week because people are attending the American Medical Informatics Association,
Yeah.
their big annual meeting, which Abel, I'll look forward to seeing you there.
Yeah,
Jim
totally.
will be there. I don't know, Matt, are you going?
I am.
Okay, good.
All right.
Have a good
We'll
weekend.
see you all there
everybody.
then.
Yep. Bye.
Take care, all. See you. Thanks. Bye.